hospitals and also in the Charlotte R. Bloomberg Children's Center. AYLIN, it's a pleasure to have you here tonight with us. We are delighted to see your lecture. Please, the spot is yours.
Thank you so much, Leandro. Thank you so much, Pablo, for inviting me. It's a great pleasure to connect with you all. As I said previously, I visited Brazil 3 times, and each and every time it was a great meeting. The meetings were very well organized, and I was truly honored to meet every one of you. And I do see Dr. Samir. Hello. We met before on one of the meetings that Pablo organized, so good evening. In the next half an hour, I will talk about neonatal brain injury. This is a topic that I personally do care a lot. Babies' imaging are not as frequently performed compared to older children or adults. And there are a lot of pathologies that can be identified early on in life. There are some tips and tricks how to better perform neonatal brain imaging, and I will try to share our experience here and show some cases. I have no disclosures. In the next half an hour, majority of the imaging that I will be sharing will be either from head ultrasound imaging or brain MRI. Head ultrasound is a great imaging tool for the newborn babies. Obviously, ultrasound waves do not travel through bone or air. Therefore, having the open fontanelles provides great access. And the larger the fontanelle, the easier the imaging. So in preterm babies, visualization of the brain is even greater. The other advantage of ultrasound is obviously it's radiation-free, and it can be performed in the bedside while the baby is in the hospital. Majority of the exam is performed with grayscale imaging, and additional Doppler evaluation can be performed. Variety of abnormalities can be identified. In this very young preterm infant, you can see the hyperechogenicity of the white matter secondary to hypoxic ischemic injury of the preterm. And the same infant, when you look at the transmastoid view, demonstrates bilateral cerebellar hemorrhages. This is another infant, and you can appreciate the asymmetric hyperechogenicity on the left side, which was an MCA territory infarction. Obviously, MR provides higher image resolution, better anatomical detail, and there are numerous different sequences which all provide different type of information. You can do T2-weighted imaging, susceptibility-weighted imaging, diffusion-weighted imaging, and then off of diffusion tensor imaging, FA maps can be generated to get more detail. And every different sequence contributes with a different level of information. So obviously MRI is superior in terms of what we can get from it. However, in an even optimized fashion, the imaging time takes about 20 minutes, including DTI and SWI in our scanners, and it requires the infant to travel to the MRI suite. Currently, we do not have a MR scanner in our NICU. There are very few centers in the world who have that. So the travel has to be factored in. The baby has to be stable enough to safely come to the MRI. In the last decade, we have progressively made improvements in imaging these babies using natural sleep. We no longer do sedation or anesthesia in our babies, and we use this protocol up to 3 months of postnatal age. To be able to utilize the natural sleep, the baby has to be prepared very well. This is not a last minute, execution. So once the decision is made to proceed with an MRI, depending on what we're looking for, patient needs to be fed and swaddled very nicely. The MRI check, safety check should be performed in the NICU, and baby should arrive to the MRI suite swaddled very nicely. That's how babies feel comfortable. They like warmth and they like being tightly swaddled, so we do that. And patient is transported, and once the baby comes to our MRI suite, they're already asleep. So we just transfer them from their little NICU transfer bed to our MRI scanner, into the MRI scanner. And we place the coil and put support on each side so that the head doesn't move side to side. They have soft silicone earplugs and ear muffs to cover the same area. And in terms of the protocol, we typically perform triplanar haste. Haste is a quick T2-weighted imaging, as you know. And in the developing brain, the immature myelination creates a really good gray-white matter differentiation on the haste. So we start with the haste, and we are cognizant of the fact that we are imaging this child while they are sleeping. So we want to get as many diagnostic sequences as we can. Haste is quick. In less than 5 minutes, you can axial, coronal, and sagittal planes. Then we continue with our standard protocol. Sometimes the order changes depending on the main question. For example, if the question is stroke, after the haste, we move on to DTI and then at SWI, and then continue with T1 and standard T2. We hardly ever give IV contrast. We only use it if the question is infection or neonatal brain tumors. Obviously, that's a very rare occurrence, but if it is the question, then we do that. There are a couple tips and tricks how you can, optimize your success. Number one, the NICU nursing team and the MRI suite has to be in touch to target the best time of the day when the baby is, sleep. The MRI safety screening should be performed in the NICU. All non-MR compatible devices, little hair clips, little tools on their clothing should be removed. And baby should come in an already sleeping, swaddled state, just so you don't, wake them up. Once you wake them up, expecting them to deeply fall asleep, I think that's not very realistic. We also have MR-compatible incubators. We scan some of our babies while they're in their incubators, which also helps our success rate. I'm going to first start with the term infant's brain injury. Hypoxic ischemic encephalopathy will be the first subject because it's one of the most frequent indications in our patient population. Unfortunately, to this date, it's the leading cause of disability and death, despite the neuroprotective treatments such as cooling. And the most pressing point is the diagnosis needs to be established and the treatment should start no later than the first 6 hours of life. So everything has to be really orchestrated and timed well. This is a primarily clinical diagnosis. In our case, our NICU specialists and neurologists make the diagnosis without utilizing imaging at first because the standard criteria for this diagnosis set by American Academy of Pediatrics and College of Obstetrics and Gynecology wants to see profound metabolic or mixed acidemia, ideally from the umbilical artery blood sample, very low APGAR scores, presentation with neurological abnormalities such as hypotonia. This is a good picture of hypotonia. Baby is like really falling around the hand of the healthcare provider. Seizures and in fact, all the way to coma can be seen. And remember, this hypoxic ischemic encephalopathy is more like an inflammatory abnormality that can affect the other organ systems. So you can find abnormalities in the kidneys, lungs, liver, heart, and even intestines. So those are other helpful criteria. Typically, in our patient population, the first imaging modality that they get is a head ultrasound. In the United States, there are ultrasound technologists. Physicians do not perform these ultrasounds, and they're trained, how to follow certain protocols. So in this patient, I think in general for hypoxic ischemic encephalopathy, whether you look at the head ultrasound or brain MRI, the top one challenge for diagnosis is the imaging findings are usually bilateral, symmetric, and diffuse. As you can see in this first head ultrasound, there is diffuse increased echogenicity of the white matter. And when you look at the gray-white matter differentiation, on the ultrasound, it is profoundly differentiated. This is an abnormal finding for ultrasound. In a term infant, the gray and white matter should blend in rather than sticking out, so differently. There is mass effect on the ventricles look effaced. There is increased echogenicity in the basal ganglia and thalami. The resistive indices looked within normal range at first. However, at day of life 4, after cooling, there is a 72-hour cooling protocol. When we look at the head ultrasound, it looks even worse. Now the ventricles started to open up, but you can see the echogenicity of the brain parenchyma has progressively increased. So this is showing the temporal evolution of the initial insult. And now the resistive indices started to decrease. In a normal term infant, normative values for resistive indices range between 0.6 and 0.8. Lower than 0.6, especially on the follow-up, has been correlated with worse outcomes. The same infant, now I'm showing the MRI. The kid was really sick. We couldn't get him to MRI between day of life 4 and 7. That's the typical MR imaging time in the cooled HIE babies. At day of life 9, we were able to get them in the MRI, and this is a profoundly abnormal MRI. Again, the findings are bilateral and symmetric. But what you see here is the T2 signal of the white matter is very high. And in the subcortical and cortical areas, in the critically or more vulnerable, metabolically more hyperactive areas, such as the area of the Rolandic gyrus, mesial frontal areas, basal ganglia and thalamus, mesial occipital areas, you do see a really dark T2 signal. This is a very abnormal exotoxic injury, and even at day 9, you can still see restricted diffusion persisting in these areas. In the cooled neonates, pseudonormalization of restricted diffusion can prolong even beyond day 9. The more severe the injury, the more this can prolong further out. So this is a really unfortunate baby. Typically, in the long run, these babies have microcephaly, profound parenchymal volume loss, and sometimes they can develop cystic changes too. This is another infant. It was a term infant, and the history was complete placental abruption. On the first head ultrasound, you can see hyperechogenicity in the thalamus extending into the midbrain. If you ever find focal hyperechogenicity in the thalamus, that's always abnormal. In this patient, it's bilateral and symmetric. And the resistive index was 0.4, which is pretty low to start with. And I will show you day by day what the ultrasound showed. Day of life 2, now you can see progressively increased hyperechogenicities now involving the basal ganglia and thalami. Sometimes it takes a little time for imaging manifestations of the ischemic injury. And at day of life 3, you can see everything becomes more confluent. The brainstem, midbrain and brainstem injuries are the worst of all HIE patterns, and these typically have highest mortality rate. This baby expired at day of life 3, never had the chance to get an MRI. But when we saw this very first head ultrasound, we were able to predict that the following days were going to look like disaster, and it did. Now, we do have access to MRI, and we can do MR in these babies, but still, when you're dealing with a neonate, head ultrasound is a very important tool. It's not that easy to transfer these babies safely. And whatever you can do at the bedside for a NICU infant, that's your top one imaging modality. As you have seen on the prior cases I have shown, we do grayscale imaging and we do Doppler imaging, and we look at the resistive indices. And because resistive indices give us numeric values, that's very attractive. We have done DTI studies to look at the diffusion changes in the basal ganglia, thalamus, posterior limb of the internal capsule, large areas of white matter such as centrum semiovale, and also in the posterior fossa, in the cerebellum and pons. And what we wanted to do was, I mean, obviously this is the gold standard of assessment of, injury. What we wanted to later see was if there was anything on the earlier head ultrasound that can help predict these findings. And the answer is yes. Low RI values noted initially correlated with ABC values. The objective of this study was to see if we could identify the worst outcome babies on DTI earlier with head ultrasound. Could it give us an opportunity to look for adjuvant therapies to stratify patients with potentially worse outcomes? And it looks promising. Neonates can also suffer from infection. As you know, sepsis is a high concern in these infants with immature immunity. I am showing two different patients side by side, and they both had central nervous system infection. The one on the left, as you can see from the diffusion changes, has the typical insular cortex and temporal, mesial temporal and temporal polar restricted diffusion, inferior frontal restricted diffusion, which is pretty much a typical pattern for HSV meningitis. And on the post-contrast images, you can see the meningeal, leptomeningeal increased enhancement. The white matter signal is also increased in this patient, which gives the impression that there is also some generalized inflammation and edema. The presentation was seizures and feeding difficulties, and further workup demonstrated this HSV meningitis. Another infant with a similar background, full-term 11-day-old, again presents with seizures and feeding difficulties, and imaging patterns are quite different. In this one, it was a GBS meningitis and had marked ventriculomegaly, which can obviously happen in encephalitis, meningoencephalitis patients. But in addition to that, you can appreciate the multifocal small areas of cystic changes with internal areas of restricted diffusion. These are presumably microabscesses, and you can see the pus in the dependent portion of the occipital horns presenting with, again, restricted diffusion. In these infants, another concern would be vasculitides. Vasculitis can accompany these infectious processes, which can further contribute to these, cystic changes. But the restricted diffusion is quite striking in this patient. Another disease that can affect a neonate is obviously metabolic diseases. When it comes to metabolic diseases, again, at the time of metabolic crisis, restricted diffusion can be seen. And in this child, you can see it in some, critical areas, the cerebellar white matter, the brainstem region, the thalamus, corticospinal tracts, and sometimes the restricted diffusion, especially in the thalamus and the corticospinal tract, can raise the concern for HIE. But I think the clinical presentation, the imaging pattern is obviously different, but in addition to that, the clinical presentation is quite helpful. The children with maple syrup urine disease typically present after day of life 4, most typical around day of life 7. Maternal metabolites help them go through the first few days of life without crises, and later around day 4 to 7 they go into a metabolic crisis which excludes possibility of HIE right there. So it's really important to know the birth, history. Obviously, recognize this different imaging pattern too, with cerebellar and brainstem involvement, which is uncommon for HIE. We talked about HIE, infection, metabolic diseases. What else can happen in the term neonate? I have shown this case early on. Let's look at this head ultrasound again, because the early ischemic changes may not be light bulb bright, but present with mild hyperechogenicity, as you can see over here. And the MR nicely correlates. On this head ultrasound read, obviously we offered the diagnosis of a left MCA stroke, and MR further showed the left MCA stroke, and we can see the early Valerian degenerative, changes in this child. This patient was on ECMO. They had history of congenital diaphragmatic hernia. This is another infant, which we have seen about a year and a half ago. I am showing the parasagittal images of the left and the right side on the brain. And on the left side, in the thalamus, you do see a focal demarcated area of mild hyperechogenicity. We proposed a small area of infarction based off of this ultrasound. Again, this kid was on ECMO. When kid came off of ECMO, MR was performed, and it perfectly correlates what we saw on the ultrasound. There is a focal small area of infarction in the left thalamus. This is another infant, term infant, and they had prenatal diagnosis of ventriculomegaly. Baby was born, and the first thing that was asked by our NICU team was the head ultrasound. We did the head ultrasound, and clearly you can easily see asymmetric left ventriculomegaly. And regardless of the imaging modality, when we're assessing the ventricular system, we want to look at the size, and we also want to look at the morphology. In addition to the asymmetric enlargement, you can appreciate the irregular nodular contour over here. This is highly suggestive of subependymal heterotopias, which is a kind of neuronal migrational disorder. In the brain, anytime you see a malformative feature, we are prepared to find more. Some of my colleagues in Europe who perform the head ultrasounds by themselves as radiologists can do more with their ultrasound. On this one, we were not really sure if the cortex here was normal or abnormal, but knowing that we were going to do the MR, we didn't worry about it too much. And MR nicely correlated with the subependymal heterotopia, the asymmetric ventriculomegaly, and it showed more. These are HASTE images, the quick T2 weighted imaging, which I said works really well because of the immature myelination, the cortex and the white matter differentiate very nicely. You can see the polymicrogyria pattern all along the occipital lobe here. And in addition, in the mesial part of the cortex here, there is a closed lip schizencephaly. You can see the cleft and the dysplastic gray matter lining here. When you look at the sagittal T2, you can see that the corpus callosum looks kind of thin, and the splenium looks especially quite diminutive. This is a hypoplastic corpus callosum, and the FA map reconstructed in the sagittal plane correlates with that finding very nicely. So head ultrasound gave us the clue that this was not just a ventriculomegaly case, there was some malformative features associated with it, and we identified multiples of it on this MRI. This is the patient that Andre and I, Andre Barreto, my dear colleague and friend, who worked with me at Hopkins for about a year's time, brilliant radiologist, whom I really adored and enjoyed working with. When he came, because I'm interested in neonatal neuroimaging, I said, Andre, there are some patients that I have, there are very few articles in the literature, and the subject matter is, and I'm going to show the diagnosis later, but it is a patient like this, for example. You do see a large area of focal hyperechogenicity, which looks like hemorrhage. You almost see a cortical boundary but I wasn't sure what I was seeing over here on this head ultrasound. And looks like there is an extraaxial hemorrhage over here. Off of the head ultrasound, we weren't sure if this was subdural or not. Nonetheless, as soon as the baby became stable, we did an MRI. And what we see on the MR, on this T2 weighted image, for example, you can see the cortex. You can see the subpial space closely attached to the cortex. The PIA is elevated, and this time of flight MRA shows the PIA very nicely, and the elevation and the blood collection underneath. And in these infants, the subpial veins, if you look at this drawing, the leptomeningeal covering is not present once the subpial veins enter the PIA. From the PIA letter to the cortex, there is no leptomeningeal covering, which makes them very susceptible to pressure changes. And in these infants, the collection of the blood here can impair the cortical venous drainage. Therefore, they develop cortical infarcts and subcortical white matter infarcts. And as you know, the white matter venous infarction has a high likelihood of hemorrhagic conversion in any age group. So that's what we see here, really. Diffusion weighted imaging correlates with the infarction in the cortex. And you can see the signal drop on the cortical layer here too. We presented our work in RSNA and received a certificate of merit. And our article, review article, recently appeared online in AJR. So again, thanks to Andrea for the great work he did with me. Now I'm going to transition to the preterm injury pattern. But before I transition, I wanted to see if anyone had any comments or questions. Very good. I hope I didn't put anyone to sleep, but I know in Brazil, this is a very early time to sleep. Just yet, dinner happens around 9, so we should be okay. All right, so in the preterm infants, the most common pattern of brain injury is germinal matrix hemorrhage. There is one question, but I think I will come back to the questions after I finish the preterm.
We can take the questions at the end. I think it's better, okay?
Very good. And germinal matrix, in fact, is present all along the ependymal lining early on during fetal life. And gradually over time, it does regress. And the most common anatomical location for residual germinal matrix is the area between the caudate nucleus and the thalamus, which is also called the caudothalamic notch. And on the sagittal view here in this ultrasound, you can see the caudate, thalamus, and this is the area of the caudothalamic notch. On the ultrasound, you can see it again. The caudate is pushed laterally. You can see the thalamus. And in this infant, the hemorrhage is bilateral, and there is also hemorrhage going into the choroid plexus. So if the hemorrhage is limited to the germinal matrix only, that's grade 1. If it involves the intraventricular areas, it's grade 2. If there is post-hemorrhagic hydrocephalus, that's grade 3. And this is how this patient evolved. It progressed from grade 2 to grade 3 within 3 days' time. Now you can see like ballooning of the ventricles with enlargement. Another infant, this is a late preterm infant, almost 36 gestational weeks. Again, you do see the germinal matrix hemorrhages, and there is this additional area of hemorrhage in the temporal region. Somehow, especially in the late preterm infants, the posterior remnants of the germinal matrix can also hemorrhage. And in this infant, this hemorrhage was attributable to a posterior temporal germinal matrix hemorrhage. And what we are seeing in the white matter here is an area of periventricular hemorrhagic infarction. This parenchymal hemorrhage, the periventricular hemorrhagic infarction, was originally named as grade 4 when Papil first introduced the germinal matrix hemorrhage classification in the 1970s. That was a study done by CT exam, and those parenchymal hemorrhages were thought to represent opening of the intraventricular hemorrhage into the parenchyma. However, that doesn't really happen. That's why we prefer not to use the grading as 4 to define these injuries. And here I will show how it really looks schematically. Now, the area of the germinal matrix is between the caudate and the thalamus, and the injury in the caudothalamic notch can impair the venous drainage of the intramedullary veins coming from the frontal and parietal areas. If the venous drainage is impaired along the white matter tracts in the intramedullary veins, it can cause stasis, and then ischemia, and then infarct, and then that infarct in that white matter can have hemorrhagic conversion, which is the pathophysiology of these periventricular hemorrhagic infarctions. And the periventricular hemorrhagic infarctions are really quite detrimental. They tend to happen unilateral, can be bilateral, but for the most part they are unilateral. And the injury to the subventricular zone, the immediate area around the frontal horn, and the germinative epithelium results in reduced GABAergic neurons, and injury in the axons can result in issues with cortical and thalamic maldevelopment. And I will show examples of how it reflects on imaging. Obviously, the precursors of the oligodendrocytes can also be injured in the spectrum of the germinal matrix hemorrhage, which would also impair myelination. So prematurity-related injuries you see are far more complex than what initially meets the eye as a simple hemorrhage. Now, the other area that is also critical and frequently injured in the preterm infancy is cerebellum. It's a metabolically very active area in the brain. There are very critical cells, and under stress conditions, they can develop cerebellar hemorrhages, especially in the young preterm, because the brain is very smooth and there is not much of a gyration sulcation. The fontanelle is large. Even from looking at the anterior fontanelle, one can find out the cerebellar hemorrhages easily. It is the same infant's hemorrhage with a transmastoid view. Obviously, when you get closer, it's an easier look. The same infant who had MRI later, and you can see the cystic encephalomyelitic changes and hemosiderin staining in the affected cerebellum. The cerebellar injuries in these preterm infants can be overcalled for malformations, which I have encountered in our practice. We receive patients who were born in other hospitals. They come to us with their prior imaging and their prior diagnoses to get further evaluation. And I have seen patients like this being diagnosed as Dandy-Walker malformation. As you all know, this is not a Dandy-Walker malformation. The cerebellar injuries, the encephaloclastic injuries, can result in diffuse volume loss of the cerebellum, which is what happened. And there is also diffuse volume loss in the brain stem and midbrain. And you can see the cerebellar vermis is even so skinny. In this patient, the posterior fossa is not enlarged at all. It is even smaller. And you can see the vermis, the 3 parts has been fully formed. You can see a nice morphology of the fourth ventricle. There is no fourth ventricular dilatation. It's just a global posterior fossa parenchymal volume loss. And in this infant, obviously, there's profound white matter injury too. You can see supratentorial brain has a lot of white matter injury as well. What we're seeing here in this infant is sequela of prematurity-related injuries presenting with profound infratentorial and supratentorial parenchymal volume loss. Coming back to the periventricular hemorrhagic infarction, the cases that we encounter, typically the very young preterms develop these devastating hemorrhagic infarctions in the first few days of life. The very first head ultrasound within 24 hours looks normal. You do another ultrasound 2-3 days later, and they have this devastating hemorrhage. On this case, you can see the bilateral hemorrhages, but obviously on the left side, the hemorrhage is also intraventricular, and there is a large area of parenchymal hemorrhage, and you can't make out any boundaries between the ventricular system and the periventricular white matter. If you pay close attention to the parasagittal view, you can appreciate the linear morphology. These are the thrombosed intramedullary veins that probably led into the ischemic changes and then the hemorrhagic transformation. Same infant with subacute follow-up with MRI. You can see T1 bright blood products in the brain and also, in the ventricular system. Long-term follow-up in about a year, now you see a hole in the brain. The areas where there was hemorrhage, patient developed a porencephalic cyst, which is the typical outcome of these PVHIs. Those porencephalic cysts typically communicate with the ventricular system. Germinal matrix hemorrhage spectrum is not necessarily a continuum. For a patient to develop a periventricular hemorrhagic infarction, they don't have to have IVH, and they don't have to have hydrocephalus. And this is a great example of it. You do see the germinal matrix hemorrhage and the small focal area of periventricular hemorrhagic infarction. If you would recall the pathophysiology of how this developed, this is a consequence of impaired venous drainage of the white matter tracts. It doesn't have anything to do with the IVH or the hydrocephalus itself. And you can see the germinal matrix hemorrhage and the parenchymal frontal periventricular hemorrhagic infarction very nicely. This is a patient, and we have a lot of surviving preterms, and because they can have intraventricular hemorrhage and post-hemorrhagic hydro, they end up with a shunt. And our standard of care, standard of imaging for shunted kids is a fast MRI. And this is the basic protocol that we do, triplanar haste, and we also add diffusion-weighted imaging. If you see a patient like this, you can picture in your brain that this is what their ultrasound looked like. There is a right frontoparietal hemorrhagic infarction, which turned out to be a cyst, a porencephalic cyst. Porencephalic cyst communicates with the ventricular system, and due to that marked ventriculomegaly, septum pellucidum has been ruptured, and you can see this patient's shunt coming into the frontal region. The porencephalic cyst develops centered, usually in the frontoparietal areas, and the size can be variable depending on how large the periventricular hemorrhagic infarction was. Obviously, in that area, there will be profound white matter volume loss and cortical thinning compared to the other areas, and typically ipsilateral thalamus and ipsilateral basal ganglia would be asymmetrically smaller as well. My colleagues, Dr. Robinson and Yancey from Hopkins, are working on a mouse model for treatment of intraventricular hemorrhage, and their objective is to see if early treatment with EPO and melatonin could eliminate shunting. If this was introduced to the ventricular system, could this eliminate their need for shunting? Obviously, that would be a great opportunity for these infants, because being shunt dependent for a lifetime is quite challenging. There are lots of complications that can happen. I think that's a really neat work, and their early findings suggest that this may become the future, hopefully, for the treatment of IVH with early EPO and melatonin, erythropoietin. Obviously, EPO is erythropoietin and melatonin treatment. And the primary thing that they focused on, what they found was that the motility of the cilia is critical, how well they respond to treatment. If the rats had preserved cilia motility, which can be enhanced by EPO and melatonin, non-surgical treatment can be an option for them. It would be incomplete if we didn't talk about periventricular locomalacia as part of prematurity-related injuries. By definition, periventricular locomalacia is a pathological term that refers to injury of the white matter in the preterm infant. And luckily, nowadays, these cystic PVLs are far more infrequent compared to earlier years of preterm survival. The cystic PVL is really a classic presentation. Currently, it's encountered in approximately 5% of the surviving preterm infants, and the sizes of these cysts can be variable from small millimetric to larger macrocysts. And typically, in the vicinity of these cystic changes, white matter would be abnormal. There would be gliosis diffusely in that area. This is another infant. Obviously, these cystic areas in the periventricular locomalacia represent necrosis, cell necrosis. And in these areas, the pre-oligodendrocytes would be lost and gone. There would be diffuse astrogliosis and microglial infiltration. So the white matter in these areas would be severely injured. The size of these cysts in this infant was quite striking, one of the largest we have seen in our patient population. I initially talked about hypoxic ischemic injury of the term infant, but it can also happen in the preterm infant. And depending on the severity scale, different parts of the brain can be affected. In the preterm infant, the most vulnerable area to HIE is initially the periventricular white matter areas. If it is severe enough, it can further include the basal ganglia, thalamus, brainstem, and cerebellar regions too. This was a twin pregnancy. One twin, it was a mono twin pregnancy. One twin died, unfortunately, and this was a surviving twin with multiple congenital malformations. On this very first head ultrasound, you can see the profound increased hyperechogenicity of the white matter, which is diffusely abnormal. And you can see it on the parasagittal images as well. The echogenicity of the basal ganglia and thalamus is also very high. And in addition, there are bilateral large cerebellar hemorrhages. Of these, what we anticipated was a profound microcephaly, profound global brain parenchymal volume loss in this patient. Approximately 2 months of age, patient was able to come for an MRI, and you can see the devastating injury on the MRI. There is significant white matter volume loss, and whatever white matter you can see is filled with cystic changes, with areas of microhemorrhages. Cerebellum is pretty much cystic encephalomalacic changes with hemosiderin staining, and you can see susceptibility weighted imaging shows the hemorrhage even more profoundly. And this coronal T2 weighted imaging shows the necrosis in the area of the basal ganglia very nicely. Thalamus has volume loss without cystic changes, but obviously there is volume loss there too. I wanted to put the coronal head ultrasound as a comparison. The injury that we see here with cystic necrosis in white matter and basal ganglia could be predicted off of this head ultrasound. In conclusion, I wanted to display the value of the head ultrasound and obviously MR side by side in a variety of injuries of the term and preterm infant. I'm a big fan of head ultrasound, not to exclude, value of MRI, but head ultrasound can show much more than a simple germinal matrix hemorrhage. And it is really good to get insight early on and prepare and counsel the families, because babies may not have dramatic neurological presentations despite devastating brain injuries. We use MR as our gold standard because it provides us qualitative and quantitative, information. And this is all I had for this evening, and I will be happy to address questions. And I can see one of the questions which our colleague from Uruguay, right, Nicolas, asked if we use MRS in diagnosis of HIE. It's not our standard part of the protocol. We do not think it is necessary to use MRS to come to conclusion in these, in these infants. So it's not our standard part of our protocol. If the question becomes metabolic disease, is this HIE? Because some of the metabolic disease can have very early presentations which may overlap with HIE. In those cases, we do them, but it's a rare occurrence for us.
Hi, AYLIN. Thank you for the outstanding presentation. As the audience is pointing in the chat, so amazing collection of cases, and as you focus on the correlation between ultrasound and MRI, which I think it's something very rich, and it's very at least here in Brazil, and I believe in many practices, not that easy to have this matching between an early ultrasound and a follow-up MRI. Sometimes it's not that easy, but amazing cases. Thank you for your presentation. You have already addressed the question regarding MR spectroscopy in HIE, as you said. If you guys, the participants, if someone has any question, you can put in the chat, and then we'll address to Dr. AYLIN. But I have a question regarding the use of CT. I mean, here in Brazil, sometimes we still struggle with not an easy access to MRI, and sometimes we go for CT more often than we would like to, due to constraining resources. So I'd like to hear from you in your practice, and what amount of CT do you guys perform in your center?
Close to zero.
Close to zero.
And the number progressively declined over time. And I think the point that you made, Leandro, is really critical. I think the reason why I have all these cases is that I work literally hand in hand with our NICU team. And in our NICU, we have multiple providers whose primary interest is neonatal neurological abnormalities. So it was like a collaborative, collective effort to do the ultrasound and to do the MRI. And as you know, there is growing concern over radiation, exposing babies, to radiation early on in life. even babies who have trauma, like sometimes, you know, they fall like accidentally after delivery, they fall off their mom's hands. Even in those babies, they don't want to get a CT. Obviously, ultrasound is not sufficient, but we have modified fast trauma protocols with MRI. We do that. I am hoping that this lecture may inspire more use of ultrasound because to my knowledge, in Brazil, radiologist performs the ultrasound, correct?
Yeah, that's it.
You know, I think that's a huge advantage because, you know, you kind of know what you're expecting to see, so you can really tailor your protocol accordingly. There is so much, you know, you can see. Obviously small subarachnoid hemorrhages, you know, you won't be able to see them, or the skull fractures, you know, would be difficult to catch too. But there is a lot that, you know, shows up on the ultrasound. But we have the advantage of being able to do those MRs in these babies. So the number is like literally close to zero annually. If we ever see a neonatal brain MRI, it's typically a referral from another hospital. And honestly, I feel more challenged reading those CTs because, you know, the density of the brain parenchyma, you expect to see hypodensity because it's the immature, you know, myelination, but it still makes me feel shaky because I don't look at them very often anymore.
Yeah, that's it. AYLIN, I have a question here from the chat, and there is also a colleague, Islam. I think there is a hand raised. But first, I go with the chat. It's a kind of a clinical question. I don't know if you can address this regarding the use of antenatal magnesium sulfate. For if you know anything about its use for preventing neonatal brain injury. Are you aware of this?
Unfortunately, I don't know whether or not it is protective or how protective. I know it is used, but I don't know the specific answer as to how much. And I'm not really sure how it is tailored in our hospital, you know, in those infants. I don't know. But I can ask my colleagues in OBGYN to see if they have a better idea, and I can get back to you guys.
Yeah. I think we as radiologists, we are kind of far from this prevention of neonatal brain injury antenatally. I mean, okay, thanks, AYLIN. And I think, I don't know, Islam has raised the hand.
Yeah.
Do you want to make the question?
I have a question, but first I want to congratulate my dear friend, AYLIN. I just caught and say hi, and I caught the last 20 minutes. I just got invited. I didn't know the time, but so far it was wonderful, AYLIN. Thank you very much. And I want to thank Pablo too. This is great. I'm cooking here. I'm reading most up-to-date knowledge, hearing from my colleague AYLIN. I love this. My question is actually, now I'm working in Florida, and in our hospital, when they have suspected fracture of the skull, they do CT, and so I cannot recommend them ultrasound because I cannot see the fracture. And MR, how, I don't have that much experience about what they do, AYLIN.
So that's a great question. I personally do not encourage ultrasound for trauma cases either. One, the assessment of fracture is limited to superficial small hemorrhages. I think the detection rate would be limited. For the head trauma, we combine triplanar haste with diffusion, black bone imaging, and SWI. It's a reduced 15-minute protocol. And black bone imaging, we previously did a study to see the value of black bone sequence against head CT to see how well we identify the fractures on black bone. It seems to have a good, like more than 80% correlation. The patient population that we had were more older than neonatal. So the way I manage that is when they insist they don't want, CT, they don't want CT, I say we're going to do this. If there is a hair fracture, non-displaced fracture, etc., the detection rate, I'm not really confident, like we may not see, but I'm not really sure if they care about those all too much anyway. So we look at the intracranial compartment, focus into that area, and look at the calvarium the best we can with black bone. Black bone shows fractures better if the calvarium is thicker. So in older ages, I think it's doing a really good job. The downside is it's approximately 6 minutes. So whichever child is having that sequence should not move for that period of time, which is a little also shaky for the neonate.
Yeah. And even for young children, like 2, 3, 4, 5.
Yeah. It's a hit or miss. Sometimes we get, really good image quality. The way I manage is I disclose the limitation. And I report it as such in my, reporting. I mentioned the limitation.
Okay.
And if people are fine with it, putting in their clinical evaluation as well, then be it,
Okay, that sounds good. It's been CT here most of the time. But
I can't convince my NICU or neurosurgery peeps to do CT in the neonate. I just can't.
Oh, no. Usually, what happens is we have images coming from 25 centers. And if the child comes to the ED, neurosurgery didn't see the child, even the pediatrician might have. So they already do it, and it's 24-hour service. So I end up reading them, but it's not that oftenly used, but it is used. So now maybe I can work on that to get them the MRI with black blood. It needs a lot of training of everyone involved. Yeah. The other question is I love that preterm baby for avoiding development of hydrocephalus, use of erythropoietin, and that's a great project. How far are they? Did they publish their results, or what is the promise?
They have published their result, and it's in the animal model stage.
Oh, okay.
Yeah.
But that's wonderful.
Yeah, I showed the rat, data. It's in the animal model stage, and
right.
I'm hoping that it may become real. And I don't know, Pablo, if I'm going over time, but I can show one image that also is an interesting. Leandro, should I stop another speaker?
No. Feel free.
Okay. We have time, sole time.
I'm sharing the screen. Okay, great. So you guys can see my ultrasound, right?
Yes.
Okay, great. So this is a child that we have seen like 2-3 years ago, bilateral dermal matrix hemorrhages, IVH, ventriculomegaly, and approximately a month and a half after they were born, it normalized. And I see this more and more commonly. Ventriculomegaly does not always end up needing shunting. Obviously, those patients are more than those who normalize, but spontaneous resolution of ventriculomegaly is also possible. And I think it's, super neat. Dottie and Lauren are pretty keen on this, ciliary function. If the ciliary function is preserved, the ventricular system can clean itself out from the blood products and then, really move on to a clean slate like this, which is, I think, phenomenal. But obviously, that animal model, I hope it works out, and I hope the babies have the option for non-interventional treatment.
Yes, that's wonderful. Most of the time, the cases we see are the grade 4 or hemorrhagic infarctions and extensive changes, encephalomalacia, and those cases. So there are still many of them coming, and we are doing MRI too at their term equivalent age. And I feel like, oh my God, I don't know if we help this child or what do they know what they signed up for. So their life will be managing this hydrocephalus, and very often those ventricles and cystic encephalomyalgias got trapped, and shunting needs to be changed, and then sometimes infections causes additional entrapment. We are chasing the cysts one time and next time another grows, and you know how it goes.
Yeah.
Thank you, AYLIN.
My
It's a
pleasure.
pleasure.
Thank you so much again, Leandro and Pablo. Thank you everyone for your kind words and your interest. It was great connecting with you, and hope we get to meet and have these conferences in Brazil, in Fortaleza.
Yeah, indeed. Pablo should invite all of us. Thank you, AYLIN, for the outstanding lecture. Thank you, everybody, for the discussion. Pablo, você quer encerrar aí, Pablo?
Thank you very much, AYLIN. AYLIN is next month to join us, to talk for us. Obrigado a todo mundo. Obrigado. Thank you, AYLIN, my dear friend, AYLIN.
We'll see you next month. Thank you.
See you next month.
Bye-bye.
Bye-bye.
Obrigada.
Obrigado. Thank you, AYLIN.
Thank you, Pablo.